The next panel is on innovation, and you're going to hear about innovation in programs, innovation in different policies, and also innovation in technology. So we're excited for all of that. And for our chairperson of the next panel, I'd like to introduce Michelle Mazzacco, Executive Vice President, St. Peter's Hospital, Continuing Care Network. In her role leading St. Peter's Health Partners Continuing Care Network, Michelle is responsible for the integration and delivery of services throughout the system, including home-based, facility-based, center-based, and every other based. So with that, I give you Michelle Mazzacco.
I'm going to take that applause as meaning that you had a wonderful lunch, right? So everybody's happy. Let's see if I can get this to work. All right. Well, I'd like to think of this part of the agenda today as dessert, because it sounds to me like you've had a lot of really great sessions, but you've heard about a lot of challenges, whether it's workforce, regulation, reimbursement. And so hopefully we can lift up a little bit this afternoon and focus on some of the fun stuff, the stuff that keeps a lot of us all energized and charged up and thinking about what can we do next and how can we deal with these challenges, because we can't keep doing the same thing and expect a different outcome. We have a great panel here today, and I'll introduce them one at a time as they come up. You're stuck with me first. I'll talk a little bit about some of the innovations across the EDDI, and then we're going to leave a good amount of time at the end for questions. So if you don't mind holding your questions for the end about any of the programs, we'll have a good amount of time for that. Deal? Deal. Okay. All right, here we go. So briefly, the EDDI, we're in the Capital Region, a nonprofit, and the whole mission of the EDDI has been to care for people in the least restrictive setting for as long as possible, and provides a full range of services. I'm going to go over a couple of areas of innovation, starting with PACE, our greenhouse model, what we're working on next with the Dementia Village, some technologies that we've been playing around with, things we're doing on workforce, and some innovations in the home-based setting. So PACE, I'm not sure how familiar everybody is with it, but it really is designed as an alternative to nursing home placement, and in some ways is a best kept secret. So the whole purpose of PACE is to take someone who's eligible for a nursing home and package a whole range of services around them in the community to either delay or altogether avoid nursing home placement. What's unique about PACE is it combines the provider of care and the insurance model all in one. So we become their Medicare insurance, we become their Medicaid insurance if they have Medicaid, and we're also their primary care provider, their home care agency, their transportation service. We provide meals, day center, everything. And the whole concept is we're duly capitated. So we take the money we save, keeping people out of the nursing home and out of the hospital, and we use it to bolster services in the community, which is what we wish all health plans did, right? And it works, it works. So just briefly, and I won't spend a lot of time on it, you have to be 55 or older, require nursing home care, and PACE is a little different. We're approved zip code by zip code, and there is a private pay option as well. Again, what makes it different is combining all of those services. Everybody gets a doctor, a social worker, an RN every single day they're enrolled in PACE. It's not something that gets authorized once in a while. We're really small in comparison to other plans, so PACE plans talk in terms of taking care of a couple hundred people, not hundreds of thousands, so we know our participants. And our doctors see 4 to 6 people a day. So you can imagine how long those visits are, and time is built into their day to coordinate with the rest of the team all under one roof and to call families and talk with them. It's an amazing concept and it works. I want to talk a little bit about the greenhouse model and the Dementia Village. So where we see things going in terms of skilled nursing care is a shift towards smaller scale living. And we did this in Cohoes years ago. We had a rehab hospital and a traditional skilled nursing facility on that campus, bulldozed them both, and built this greenhouse campus. There's 192 elders living there in 16 houses that look like this on the outside. That's a nursing home. And on the inside, has some resemblance of our own homes. The dining room where families come and have dinner with the elders and our staff, private bedrooms and bathrooms, and their own backyard that they're free to use whenever they want. And then it's a different staffing model using a Shabazz role that does a variety of things in the house. So the Shabazz is not only the CNA, but also the cook and the housekeeper. And outcomes kind of speak for themselves, right? So it's all the things that you would expect with the small scale living model: colleague satisfaction higher, resident and family satisfaction higher, and outcomes better. The challenge and why you don't see more greenhouse models, you'll guess, the state pays us the same as they do a traditional nursing home. And it does cost a little bit to get this kind of a model up and off the ground. And operating costs are slightly higher. The next thing that we're looking at is the dementia village concept, and it's based on the programs in the Netherlands. They're actually decades ahead of us. They've been doing this for 30 years. This is also about small scale living for those needing nursing home care or memory care. And it's way more than, you'll see some programs will say they have this model just because they did a little bit of an architectural change. That's not it. That's not the dementia model. It's changing the culture, it's changing the staff training, it is changing the design. We'll be building in a store and a post office, possibly a movie theater, a park, for residents to be able to enjoy the outdoors much more than what you typically see, and indoors. And the other big differences are, I'll go back. When we met with the folks from the Netherlands, we asked them about sundowning, and they had no idea what we were talking about. So when we probed that a little bit further, because their elders are so active, because they're outside and so active all the time, they actually are tired at night and they sleep. Yeah, and they take less medications. The whole model is different. They have waiting lists of kids from college and high school waiting to come in and volunteer at the nursing home, to walk the dogs that live there with the residents. They totally integrate the nursing home in the community that it resides in. Clubs from the community meet at the nursing home. They don't meet out in the community. And so the residents can participate as well. It's just, we're excited about it. Some other quick things in terms of technology. We installed an artificial sky in the memory care unit at one of our nursing homes, Our Lady of Mercy. The only problem we had was one gentleman wanted to go outside without his coat on in January because he thought it was sunny. But really that has helped with sleep cycles. It has helped with engagement in resident activities, and has not only been a better environment for the residents, but also for the staff. The other thing that we're piloting is smart cell flooring. So this doesn't prevent a fall, but it does prevent a fracture or a break if they do fall. And you can literally drop an egg on this and it won't crack. It's expensive. We used a grant and we'll be doing an evaluation study on this, and we'll share that with all of you. But that's some of the new technology that's coming out, because we all know falls are a huge issue. We're using a grant for virtual reality with our residents and our PACE participants and our adult home residents as well. Just engaging them more in different activities and technology, and where you think that some elders might not be interested in this, they love it. They're skydiving, they're deep sea fishing, they're doing all kinds of crazy things. In our retirement communities, we're working with smart home technologies, so everything from Alexa to Speak To and some other technologies that just make life easy. So if you come in, you don't have to find the light switch, it just turns on. And it might use motion or it might use your voice, and just trying to make it easier and anything that would reduce the chance of falls. On the workforce front, we're doing two things. One is we hired a colleague success coach a few years ago, and this has been a hit. It sort of is very different than the phone-based EAP programs, and this is someone that the staff just get to know. The types of things that she's helping with on a routine basis are very basic: food insecurities, housing issues, transportation, domestic violence, you name it, how to access governmental programs. But the difference that she makes in the lives of our colleagues is huge. And these are all the challenges that they're facing every day that make it impossible for them to come to work and stay at work. And then we hired also career coaches. So many of our jobs are entry level, and people look at them that way. They don't come to work at some of our organizations thinking they're going to stay there forever. And the turnover rates are astounding and costly. This is to turn that mindset around and to say, come and start with us in an entry-level job, but then stay with us, and we will guide you through whatever short-term, long-term career goals you have, and support you in getting there. So those are just some things we're doing with workforce. And finally, in our home care agency, we're partnering with some EMS programs and the Home Care Association of New York State implementing community paramedicine. So these are the folks who are constantly calling 911 and probably really don't need to go to the ER, and now there's an option. The EMS visits them in between our visits. They stay involved with them after we're discharged if they need that support. And when they call 911, there's an option to treat at home or to transport. So that really will help to free up some of the ER resources and probably get a better outcome for the patient. So now it is my pleasure to introduce Dan Reingold. Dan is the President and Chief Executive Officer of River's Edge and Vice Chair of Riverspring Living. And they have some amazing programs and some really wonderful services.
Good afternoon, everyone. Thank you for that lovely introduction. We have limited time, so I'm not going to talk as fast as Greg did, but I'm going to limit my description of Riverspring Living so I can talk about something that I think is much more important to us, particularly when I look at the title of this session, which is Innovations for Personal Care. Just quickly, Riverspring Living, our website will give you kind of all the information. We are an organization that started 107 years ago as the Hebrew Home at Riverdale, and over the course of the last 15 years, we've evolved into Riverspring Living. As a nursing home, we were serving about 1,000 people. Today, we serve 18,000 people through a comprehensive series of programs and services, which include a managed. This is an image of our campus. We're located on the Hudson River in Riverdale, and we now have an MLTC that serves the greater New York City area. We have the nursing home, which is the Hebrew Home. We have assisted living, home care, Elixa, middle income independent living. During COVID, we used that time to develop two affordable housing buildings with services, this one on Boston Road. These are serving a population of older adults who were either homeless or at risk of being homeless, and are now in affordable services on a subsidized basis. And here's the Arthur Avenue apartment, which is a LEED certified building located in the South Bronx. Each of these is about 177 units, and they're beautiful apartments costing the system significantly less than if folks were either in a homeless shelter or in a nursing home. The technology in our organization is significant. We received a $10 million grant from a donor who wanted us to become the national leader in technology around older adults. And we've been beta testing all kinds of new technology in our organization. What you're seeing here on the right is something called 0G, which is a phenomenal assistive device to help people get back on their feet. And we have, again, just a whole host of various technologies that we're trying out, beta testing. And if they work, we use them. If they don't work, we don't use them. And a lot of sharing of that as well. On the workforce front, we have 3 programs designed to encourage workforce in our field. The first is that we've set up a CNA school. We have a program with our neighbor, the University of Mount St. Vincent. And we have a program called the HOPE program, Healthcare Offers Permanent Employment. We run a high school within the nursing home for New York City high school students who are on the spectrum and cannot function in a large impersonal public school. And we're proud to say that we have the highest attendance rate of any alternative high school in New York City, as well as the highest, thank you, as well as the highest graduation rate. And the key there is that each of the students who is in the program is guaranteed a job within our organization if they get their IED degree and complete the program. Thank you. The last thing I want to touch on, I'm sorry, this is River's Edge. River's Edge, actually my new job, I I relinquished the CEO job at Riverspring Living a month ago. It was a planned succession after 35 years. And I'm now the CEO in charge of developing River's Edge, which will be New York City's first and likely only life plan community on our campus. So stay tuned for that. If you want to live a long life, try to build a life plan community in New York State. The last thing I want to touch on is the Harry and Jeanette Weinberg Center for Elder Justice. I think probably the legacy that I'll be most proud of when I look back on my career was creating the nation's first emergency shelter for victims of elder abuse in the community. I was really stunned to read the Master Plan on Aging to see that there's not one mention of what we're doing about the epidemic of elder abuse in this country or in the state. 1 in 10 older adults is a victim of elder abuse in their community. Elder abuse in the nursing homes, which should be non-existent. Unfortunately, it's not. But it pales in comparison to the number of people that are abused in their own homes. They are essentially prisoners in their own homes. And what we did is that we are using our nursing home as an emergency shelter with a team of lawyers and social workers. And I urge all of you to go on and look at it. We need shelters in every community. And it's a wonderful use of a nonprofit nursing home. It's a limited use. I'm happy to talk about it more offline. But it is an epidemic, and it's getting worse by the day. And we're not doing anything to really remedy the situation. You've heard also, I want to just shift gears for my remaining time and talk about, to me, the bigger issue. What I've tried to do in our organization over the last 15 years is get away from being a nursing home and be much more focused on a comprehensive program that is holistically devised and designed to really address the needs of older adults. And you've heard today, I mean, one thing that I'm going to go away from this program is the system is broken. It's completely broken. I mean, we are rearranging deck chairs on the Titanic, ladies and gentlemen. What are we doing? And we're spending tens of billions of dollars to do it. So I'm here to tell you, especially you fellow baby boomers, let's break this thing down and blow it up. I mean it. I really mean it. Let's go through. Let's review what we've learned today. Okay. The long-term care system in New York State is completely broken. It is siloed. It is not consumer-friendly. Yesterday, in the CEO magazine, New York State was once again rated as the 49th worst state to do business in. It's even worse than that if you're running a nonprofit or healthcare organization. Lou, I warned you. Us baby boomers have blown up every system that we went through. We blew up suburbia, we blew up child rearing, we blew up college campuses, we blew up, we were yuppies, we blew it all up. We all thought that we were going to die without ever getting old. So we didn't bother blowing up the long-term care system, and now we're here. And it's late, ladies and gentlemen. We need to blow this damn thing up, all right? Let's talk about all the Medicare growth and people bitching about the MLTC system. Let me tell you something. The reason Medicaid is growing is because there are more people using it. It's simple. And more people are using it because more people are getting older and people are disabled. And us baby boomers, we're not going to die without getting old. We're going to die with chronic illnesses and chronic impairments that are going to need expensive care. The other thing I want to remind everyone is growing old is not an illness. It is not a healthcare issue. It is a social determinant, and we've got to get away from this model of treating old age like it's a healthcare issue and having a place called the Department of Health govern every single thing that you do. We've been running nursing homes in this state since 1965. Can I tell you something? They don't look any different today than they did in 1965. There's still a goddamn curtain between the beds. That's your privacy, and you get to have a toilet, and if you're lucky, you get a sheet wrapped around you so you can go down the hall for a shower. That's not dignity. And we're paying $100,000 a year for that privilege? How many of you in this room are looking forward to going to a nursing home? Can I get a show of hands, okay? And we're spending, $22 billion a year on it in New York State. There are 600 nursing homes in New York State, 111,000 beds. 50% of those beds are filled with people that do not need to be in nursing homes. Let's close those beds. Let's get rid of the for-profit nursing homes, which are ripping the system off. By the way, the same people that are bringing you the problems in the MLTCs are the same people that are running the for-profit nursing homes. Take a look at who they are, all right? So half of these beds are not needed, and the other half aren't wanted. But we have an entire bureaucracy that does nothing but regulate them and dole out the dollars and not pay enough. So what's the plan? What do we do? What do I have in mind? Well, for anyone that heard Greg this morning or has had the benefit of listening to Becky about Area Office on Aging, I say let's shift resources to the counties. Counties know what's going on in their communities. They know what is happening. Long-term care, ladies and gentlemen, is local. It should not be dictated by the federal government that has no idea what's going on in communities, and it shouldn't be dictated by the state, which has no idea. What happens in Steuben County is completely different than Bronx County, but the regulations are the same. What are we thinking? So I say shift these resources to the offices on aging and let them network within the counties to develop programs and services that will meet the needs of the residents. Look at what, you heard Becky this morning, look at what $1 gets you in an office for aging versus what $100,000 gets you at a New York State regulated nursing home. Look, so that's key. We need to stop depending on the federal government and the state. Take a look at, we have an opportunity here, and if we don't do it soon, we're going to be really stupid. You can buy a Embassy Suites hotel right now for $100,000 a unit. Imagine, and these are hotels that are dying on the vine. You could walk into an Embassy Suite hotel right now, and it is ready-made for affordable housing for services for the aged. It has a concierge desk, it has a dining room, it has a fitness center, and every room is ADA. And they're ready to go. For $5 million, you can pick up a 50-unit building in New York State right now. Go try to build that building. It would cost $40 million to do it. And if our state doesn't recognize the opportunity here to have affordable housing on a turnkey basis, they are really missing the boat. There is technology today that is off the shelf that we can use in people's homes. It's off the shelf to keep them safe. It'll tell you how many steps they're taking, whether they use the toilet, whether the refrigerator was opened or closed. We ought to be putting that $22 billion that we're spending on 250,000 people. Do the math, ladies and gentlemen. $222 billion being spent on 250,000 in the state of New York. Let's just take half of that and revamp long-term care in New York State. We can take high schools. Not every high school kid has to go to a four-year college. Let's get into these high schools and show young people that there's a career path in becoming a certified nursing assistant. Let's take scholarship money and give it to nursing students to say, look, we will pay for your nursing education if you commit to 4 years of being a nurse in a long-term care community, home care or nursing home or assisted living. We will have nurses lined up to work in our communities. Use the Uber model for transportation and delivery of food. It's there. It exists. You don't think Uber would love to get into this space? With a little bit of technology, we can solve the transportation and food delivery problem instantly. I could go on, but I can't do it all in 10 minutes. So what I'm going to leave you with is this. I'm proud of the work that we've done at Riverspring Living. I'm happy to hand it off to my number two and to be building this life plan community. But what I'm really going to be doing for the rest of my whatever days the good Lord has for me is to really try to advocate for change. It is late in the game, and I hope that all of you will join me in blowing the system up and rebuilding it in our image. Thank you.
Phenomenal, and I think we should just vote right now and elect him. All right. So our next speaker, you're going to really enjoy meeting Bob Hartman. He is the Vice President of Product Design and Strategy for MVP Healthcare.
Tough act to follow. When you all think of innovation, I'm sure the first thing that comes to mind is health insurance. So That's why I'm up here today, to hopefully dispel some of those preconceived notions you might have and show how MVP Healthcare is helping, with the innovation and helping our customers and our neighbors, age in place and age gracefully. So do a quick overview of MVP in like 30 seconds, maybe less, and then I'll go over three major things that we're looking at. So the first, MVP here you can see is a regional nonprofit health insurance organization servicing New York and Vermont. We have Medicare, Medicaid, commercial, fully insured and self-funded. For today, we'll focus on Medicare Advantage and our dual eligible special needs plan for those that are eligible for both Medicare and Medicaid. When we think of innovation, we need to think about the customer at the center. And so when we're putting the customer at the center, and I'll use the term customer, that's how we view our members, our customers, patients, neighbors, whatever you want to call them, but the person has to be at the center. And what we're striving for in everything we do is to be on their side, to provide access their way, and to be their community expert. And so I'd like you to think about everything that follows in that context of, are we advancing those things? Are we being successful in keeping the customer at the center of what we do? And so I said there's three things I'm gonna go over. There's 5 on the slide, so just, math was never my strong suit. That's why I'm in product, not actuarial. But we'll go over GIA, care guides, and then just supplemental benefits. So what's GIA? GIA is our digital experience for our customers. And so it's more than just an app or a web portal, but it's the guide to your health plan and a guide to your health. And so it's more than just an ID card or benefits information or claims information, which is table stakes at this point. You need to have access to that information. But it's also our telemedicine platform and the ability to get care online. And now, telemedicine, it's 2024, Bob. This isn't a panel on innovation, and you're talking about telemedicine. I want to talk about primary care. I want to talk about, think about telemedicine and urgent care in your sinus infections. Sure, that's table stakes again here in 2024. But what about virtual primary care? What about virtual behavioral health? You look at our visits, you look at the information, and these things are needs in our community to get the care where they need to get it and at the best time for them. And so those are things that we're offering and we're continuing to expand. So let's talk about care guides. Healthcare is confusing. I'm sure that's the most profound statement you've heard today, but it's confusing and it's hard. And you can have all the technology, you can have all of the innovations around the customer you want, but if you're not augmenting that human experience, what are you really doing? And so without going on and on about what a care guide is, I thought I'd let one of the care guides speak for themselves and tell you what they do.
Hi, I'm Johnny, a care guide at MVP. Healthcare is confusing, so when customers call, our mission is to improve health and provide peace of mind. Recently, a frustrated member called because he was having trouble obtaining an urgently needed prescription. He had Medicaid coverage with MVP, but I later learned that he also just started Medicare, helping him require making several phone calls, including to New York State of Health, Medicare, and his pharmacy. I assured him that I would stick with him until the matter was resolved, and he told me, "I trust you 100%. I don't know why, but I do." His prescription was ready for him later that day. I also connected him with someone who could enroll him in a better plan for his needs. After spending more than an hour and a half with him, he thanked me, saying, "I've never spoken to someone who cares as much as you do." Building that trust and adding that personal touch is the difference we make every day.
Now, yeah, Johnny deserves more than applause. He does wonderful work as our other care guides do. I'm just getting over a cold, so I don't have the energy to burn it all down like the previous speaker. Healthcare shouldn't need an hour and a half on the phone to deal with those types of things. These should be things that are just given to you in a right. But The current situation, the current system requires that we are hand-holding, we're alongside them, and that we're not, putting the customer in the middle, as in the providers on one side and the insurers on the other side, and they're fighting with each other, and so you've got someone in the middle, but we should be around the customer. And that's the idea behind the care guide, is that we're surrounding the customer, surrounding the patient with that hand-holding and with that care, delivering that care. Oh, I must have gone too far. Okay, sorry. The final slide I have here, as you can see, is supplemental benefits. So again, putting the customer at the center for our Medicare Advantage, for our DSNP, our dual eligible special needs plan customers, we're providing that transportation to the free transportation to their doctor's appointments. We're providing meal delivery after a hospitalization. If there's a new diagnosis of diabetes or congestive heart failure, there's several weeks of meals being delivered to help them cope with that new condition and deal with the nutrition that they need to get better. And then finally, in some of our plans, we're piloting out things called care kits, where if you have a new diagnosis of diabetes or congestive heart failure or a joint replacement, instead of saying, here you go, good luck, you're out of the hospital, let us give you some tools to help you with that condition, help you with your new lifestyle. So thank you for your time today, and I'll hand it back over.
And now it's my pleasure to introduce Becky Prevey. She's the Executive Director for the Association on Aging in New York. And I know you heard from Greg earlier, and I think the offices on aging are really trendsetters in this whole area. So welcome, Becky.
Hi, everybody. First and foremost, I want to thank Lou and his team for hosting this, and to thank all of you. It's so nice to be in a room full of people that are all rowing in the same direction about equity and about ageism, and so I appreciate all of you. I am going to talk just as fast as Greg because we work together all the time, so my cadence has been adjusted. And as you can imagine, Dan is my new best friend, and he will be coming to Albany with me in the coming months. So I'm going to leave this up here for a minute. Many of you approached me after my comments this morning. I can't underscore how important it is for elected officials to hear our voices. You guys are subject matter experts in the work that you do. My email is up here. I welcome any and all of you to join me. We definitely had some wins this year in gaining awareness. We had over 200 organizations that joined the 59 area agencies on aging throughout the state to send a letter to Governor Hochul and to our elected officials. I welcome all of you. Send me an email. You will hear back from me personally, and you will be included in our advocacy efforts because you are the people that we want to hear from. That being said, I didn't know we could go off script, so I am going to talk about innovations because I do think that Dan covered a lot of the comments that I think all of us feel. Greg talked a lot this morning about innovations that have been done in conjunction with the New York State Office for the Aging. I will tell you unequivocally, we are leading the nation. Between Greg and myself, we are asked to speak nationally on a regular basis. We have over 30 other states that are trying to replicate the work that's being done by the New York State Office for the Aging, and with the 59 offices for the aging throughout the state. So I could not be more proud of the work that we're doing. And although Greg talked about a couple, there's a hole up here, a couple of the innovations, I wanted to dig a little bit deeper on some of the innovations that we're doing that are really targeting healthcare and healthcare outcomes. And selfishly, I'm going to start with the Everhome Columbia pilot project because I chair the committee. And am really proud of what we have seen in Columbia County and the surrounding areas. It's basically embedding tech and care coordination and making sure that they're integrated. It's wonderful to have tech, but if you're not integrated with care coordination and case management, you're not going to really get the biggest bang for your buck. It embeds the use of telehealth. There's a lot of conversations under the previous waiver of keeping people out of emergency departments, out of skilled nursing facilities, and out of the hospital. That makes sense from a budgetary standpoint, but I don't know anybody that likes going to the emergency department, especially if it's something that could be managed with telehealth services. Again, caregiver support and linkages to free services available. If you don't know about the service, you're not going to engage in the service and you're not going to get the health outcomes. So making sure that those linkages are made is really, really important. And then 24/7 monitoring and integration for clinical outcomes. What's an actual example of that, right? I get asked that all the time. Well, if my mother is using artificial intelligence and sensors in her home, I'm going to get an alert if her bathroom pattern is normally she gets up once a night to go to the bathroom. If she's up 5 times 2 nights in a row, ding, ding, maybe a UTI. You can catch clinical outcomes way quicker through the integration of these services. And through the pilot project, we're seeing really incredible outcomes. So it's just one example of how you can really marry all of these service systems to drive down the overall cost of healthcare. Is anyone here familiar with BIP? All right, very limited. So BIP was one of these federal waivers called the Balancing Incentive Payment Program. Erie County did a pilot with BIP Innovations funding, and this ties back to that conversation about funding that we have. When I talk about the outcomes of this program, the fact that it wasn't continued with additional funding is the reason we have a healthcare crisis in the state of New York and in the nation, because we don't continue to invest in things that make sense. So we have a very robust New York Connects program, which is our Aging and Disability Resource Center. It's basically services birth to death. You can call if you have a question about a child with a disability, all the way up to, I need to put my mom in a skilled nursing facility. And what they did is they brought that to hospitals and skilled nursing facilities for care transitions. To really complement discharge planning efforts. I will tell you, prior to the work in geriatrics that I do, I was a hospital discharge planning social worker. One of the most difficult jobs I think that exists. I wish I would have had this in my local community, because it changes how you do discharge planning for your individuals. We know that the biggest gap in services and the most risk is in that transition, either from a nursing home to home or from a hospital to home. There are so many things that can go incredibly wrong with the clinical picture. And if we can address those issues, you're going to save long-term healthcare costs. And again, warm handoffs. We talked a lot about MLTCs today. We talked about waiver. We talked about PACE. There has to be a warm transition through those service systems. And the biggest frustration that a lot of providers have is if you're working with an older person, they might have 5, 7, 8 agencies that are all care managing or case managing, trying to coordinate care. This allowed a warm handoff where everyone knew what their role and function was. And again, I hate to have to talk about return on investment when you talk about the most vulnerable members of our population, but that's the society we live in. It saved $3.41 for every dollar invested. And again, it was an innovation, it was a pilot, it did not receive ongoing funding. We could be saving millions upon millions of healthcare dollars. Another BIP innovations in Monroe County, which we have been able to get continued funding for, is the Community Care Connections, which is run through Lifespan of Greater Rochester. For those of you that don't know, I know he's a member of their board of directors. Lifespan does an incredible job not only supporting older individuals, but also combating social isolation, loneliness, elder abuse, and fraud abuse prevention. And they integrated community-based setting services through physicians' offices. Again, these were social work services, linkages to community services and nursing services. We have 41 of the highest level evidence-based interventions through the 59 offices for the aging, including chronic disease self-management, diabetes self-management, falls prevention. And what we looked at is really with that embedding in the primary care physician's office, because you guys know this, when you get to your doctor, you have 7 to 10 minutes to unload a year's worth of issues. The physician does not have time to talk to you about installing a handrail in your bathroom and how that universal design options can really allow you to stay in your home. And again, the outcomes and the metrics to these small interventions of making sure that the clinical services are embedded with social services provided by the local offices for the aging, decreased emergency departments visits by 62% in 90 days and 72% over 180 days. So this wasn't anecdotal that it worked for a little while. And again, when you look at the return on investment, almost $5 was saved for every $1 invested, to the tune of over $2 million. These are the types of services and supports that are going to change the long-term care infrastructure and how we're able to deal with the additional older population that we're seeing in the state of New York. I referenced this morning. We're currently 4th in the nation for individuals over the age of 60, but the fastest growing segment of the overall population in the state of New York are those over the age of 80. Of that population, about 70% of people are going to need some type of long-term care support, whether in the home or community or in a skilled nursing facility. And, to points made earlier, I'm not great at math, but if you have, 4.6 million older people and you only have 111,101 skilled nursing facility beds, the game is in the home and community-based service infrastructure. A lot of the work we've done at the association over the course of the past couple years is to make this case not only with state government and federal government, but also with plans. And you can see from many of the colleagues here today, plans want to be in this business to provide holistic care, but it's been a very siloed market. We use the word silo a lot today. So again, we have 59 offices for the aging throughout the state. Predominantly, they're based within county government. That's not a bad thing. It's not a good thing. It's just what it is. But what we found is that the 59 offices for the aging provide all of the social determinant of health interventions that we talk about, that's talked about under the waiver, that's talked about in long-term planning options, transportation, home delivered meals, health insurance information assistance and counseling for those really obtuse programs. So we're providing all of those services. We talked about this morning. We don't have enough money to serve the population that we're trying to serve. We should be able to market our services to plans to actually pay us for the integration of services that we provide. And so what I found when I came to the association was that it's not that the offices for the aging didn't want to enroll in contracts, but it's county-based government, so it's very difficult, it's very risk averse. And if I'm MVP, I don't want 59 individual contracts because that's just a nightmare. You want one contract that's going to cover a region or the state. So what we did is, as an association, because I do represent the 59 offices for the aging, we wanted to protect our core membership organizations. So we created a sister 501c3 not-for-profit who now hosts an independent practice association called the Healthy Aging IPA. Why is this important? This is a mechanism where on behalf of my members, we can contract with plans to absorb the costs that plans should be absorbing on behalf of the clients that we're serving, because we don't receive enough federal, state, and locality funding to be able to support those individuals. So I am very proud of this. The board of directors and I worked very diligently to launch this project, which has been finalized this spring. And the plan is to have ongoing conversation with plans in order for us to receive payments so we can actually support that almost 5 million older people in the state of New York that really need these low-cost, really high-yield services. And I think the takeaway, if I'm sitting in a different lens, which we all kind of come in with our own lane, if you need to save the long-term Medicaid crisis that the state of New York is facing, to Dan's point, we have to invest in home and community-based services that support people for less than 10 grand a year on average for 7 years and allow people to age in their homes and communities. Thank you.
That was awesome, Becky. Thank you. Now, a presentation on innovation would not be complete without a discussion about AI. So it is my pleasure. And Beth, do you have this technology set up for Charlie? So Charlie is the co-founder and chief operating officer at AI Nexus Healthcare. And he is remote, so we'll be switching over. Hi, Charlie. You can hear us?
Hello. I can. Can you hear me?
We cannot hear you.
Oh.
Not yet. Say something again?
Can you hear me now?
No.
I feel like the Verizon guy. I think the people in the chat can hear me, so maybe something in the room.
How about test the microphone?
Testing, testing.
We're hearing music.
If I could sing, I'd sing along.
Yay!
Oh.
Take it away.
All right, and I will share I think I'll probably have to run my own slides here, so I will go over and put this into presentation mode. Well, thank you very much for having me. Thank you to Lou and the team. Thank you to the other panelists. I continue to learn a lot as somebody from kind of the technology world and not necessarily living day in, day out in the elder care space. It's always so gratifying to be able to spend time with experts such as my panelists and everybody in the audience today. So I'm very appreciative to be able to share and participate today. So I am the co-founder and chief operating officer of AI Nexus. We are focused on building health screening technologies that, to use, Dan used the phrase off-the-shelf technologies, how valuable those can be. Our mission is to use those technologies, in particular the smartphone. I don't know if from my background you're able to see the phone, but to be able to do the same things that typically you would need medical devices or medical professionals to do. This is not with the goal of being a substitute for medical expertise or even the expertise of caregiving professionals. And I think that, as I was listening to the panelists, I jotted this down. I mean, I'm going to be talking about artificial intelligence, but there is no artificial empathy, and for a reason. So everything I'm going to outline here today, I view as hopefully tools that can be augmentation to existing workflows, existing staff members. If you're your best staff member, be it on the provider side, the plan side, long-term care, if you could clone them and have 100 of them running around the facility, keeping an eye on the others, keeping an eye on the people you're caring for, that's really our objective here. So this is really why our company exists. We've done a great job over the last 50, 60 years of helping people live longer, but we don't always do a great job of helping them live a better life, particularly towards the end of those lives. And this is research that's come from McKinsey that typically with each year of life expectancy that we've added, it comes with 6 months of poor health. And fundamentally, often this comes from chronic diseases that the early indications of have manifested much earlier in life than in the golden years. So our objective is to provide technologies that are able to pick up the signals for these potential illnesses, alert the individual while it's perhaps at the stage where a lifestyle change or a modification of behavior could have an influence on the course of that disease developing. And to the degree that the disease becomes significant enough, or in an acute case, if it's immediately significant, alert the people that care for that person, be they providers, plans, family members, whoever would have a vested interest, and get that person taken care of much earlier than they otherwise would. So hopefully when they are in their later years, they're in a much more, they have a much more stable foundation from a health perspective. So in our view, AI can be a key facilitator in this regard. I think all of the innovations that we heard about today are really just fantastic, and AI certainly is no substitute for that. And if we had an infinite number of people with the passion and enthusiasm for all of the great work that all of you are doing, we wouldn't have a problem with some of the problems that have been addressed today. So our view is that early warning is key. Not just detection, but also potentially prediction. Becky mentioned some of the work in one of their projects where using AI to predict the incidence of UTI based on movement. We're looking at similar projects, including medications people are on, lifestyle habits they have, mobility that may increase their proclivity for certain health issues. But doing this is quite difficult. Anybody that proclaims that they have an AI or an algorithm that is going to replace anybody's job is I think being a little bit disingenuous. From a health perspective, you need to take into account all of these metrics, everything from symptoms and history, medical history, family history, the social determinants of health, biometrics and vitals, lab tests, mental health being critical, and understand how things like sleep and diet and physical fitness affect each one of these, and how the just understanding these things can be translated into a personalized care plan for each individual, that if they're capable of caring for themselves, fantastic, translate that to them on in a personalized way. And if not, give their caregivers superpowers so they're able to do a much better job taking care of that individual and also all of the individuals that they're looking after. So this is a high level of the platform that we built at AI Nexus. You see in red, I've highlighted our human advisors. We work with specialists both in the medical field and also very interested in working with experts in the social fields and any field to encode their expertise as a critical component in our software. So we can do a lot of clever things that I'll get to, including taking vital signs and biometrics from a camera with no other devices. I know telemedicine has come up a couple of times here. That's a service that we can integrate with. Is remotely in a session such as this, push a button and get everything from heart rate to blood pressure. But one single reading isn't necessarily significant. So, we're very interested in understanding the trends with people and how those relate to all the other things on the preceding slide that create this total picture of somebody's health. So in blue, I've highlighted what we call a cognitive AI brain. This is where that knowledge sits. Above that is a type of AI that you may have heard of called machine learning that's really good at finding patterns in data. Anytime someone's trying to present a solution that are you overwhelmed with data? We give you insights. Typically, they're using some form of machine learning that's really good at finding patterns. Like if you give it images, it can see things that we can't see. The COVID vaccine was actually developed using a model, the machine learning model, that was able to kind of cluster different biometric parameters and metrics that humans never thought of clustering together, and the machine learning figured it out. So certainly valuable. But the machine learning doesn't have any ability to make inferences. It has no reasoning capability. It has no experience to lean on. And fundamentally, it has kind of limited value in a life or death situation. So we look to combine that with the cognitive AI, as we term it. And now we're working on, you may have heard of generative AI or large language models, ChatGPT being the most well-known. ChatGPT is a fantastic tool, but I like to think of it as kind of the mouthpiece, not the brain of a system. So we can give something like ChatGPT parameters about an individual, for example, their age, their demographics, their medical history, and ask it if we've loaded it with credential advice for a customized care plan for this particular individual, but make sure we're checking it against the expertise modules that we've gotten from our human advisors to ensure that nothing inappropriate or potentially dangerous is being communicated to the individual. And I have the Mayo Clinic logo up there. We've validated some pieces of our technology where from vital signs, we're able to match the accuracy of a one-lead ECG for a number of different cardiac conditions. So for a variety of arrhythmia, including AFib, all the way through congestive heart failure and heart attack, just using the vital signs. So we're hopeful that in combination with our technology of taking vital signs from a camera remotely, if we can combine that with our algorithms for detecting cardiac events, we now have a pretty powerful suite of technologies on that front. So this is fundamentally our kind of our goal, and to a degree, the product that we have developed at this point. We can detect over 20 different health metrics from a scan of either the face or the finger of the individual. We're not saving any images of the face. We're just purely taking real-time readings, everything from the biometrics, blood pressure, oxygen, heart rate, all the way through looking at the face for signs of asymmetry that could be consistent with stroke or other neurological diseases. We have work going on now to look at the tracking of the eyes for early indications of dementia, Parkinson's, and Alzheimer's, as well as other issues that are potentially more acute, for example, concussion, if somebody has fallen, and combining that with some of the algorithms that are involved in predicting somebody's likelihood for falling, including their sleep patterns and the medications that they're on. And this is kind of the overarching vision. We have a dashboard that we believe can be very useful in sort of stratifying individuals, triage, alerting caregivers. I know that it was mentioned too about the elder abuse that Dan had commented on. Among other things, we're hopeful that if a facility was open to it, there's no reason this information couldn't also be shared with family members. They could in the course of messaging with their family member, get some biometric baselines, see the movement patterns, get an alert themselves if there's elevated fall risk, to the degree that that's manageable given liability constraints. And really, there's really no limits as far as the insights and advice and personalization that this technology can deliver if used appropriately and fundamentally in the hands of trained professionals who are able to not only help improve it and deliver the insights it needs to provide value, but also in a home care or for lower income communities, transfer some of that expertise into those environments. So if you'll permit me, I'll just show a quick video of some of the technologies in action. Let's see if I can perform these gymnastics without hanging up on everybody here. Okay, so hopefully you can see my screen still. So this is a biometric screening happening through the camera. This is our telemedicine demonstrator. So shortly here, you will see the biometrics have come through here. I think I can, oh no, I can't zoom in. My apologies. The biometrics have come in here, everything from heart rate to blood pressure. Below is the arrhythmia screening, and this is the symmetry analysis of my face. We have a mesh that has 500 points with a millimeter degree of precision, looking for signs of asymmetry. If we have a hit on that static, that technology can work off a photo, so if a selfie or other saved image, we can reference it with preceding images. If we see something of significance, we can move to a multi-pose model, which I'll show you shortly. This is the technology working in a moving vehicle at night. It's very tolerant of light and movement constraints, which could be of concern with certain individuals. This is a detection of drowsiness and head movement. This can also be used for people that are under medication to see how those reactions are being undertaken. We have a module for skin cancer detection. This can be used for wound and pressure wound analysis too, to understand if somebody is in urgent need of attention. We're using a similar framework that a dermatologist would use in this instance. We have an assessment for Parkinson's. Not only our work on the eye, this is a model that looks at drawings. So we ask the individual to draw a wave and a spiral. From this, we're able to get a signal of whether there could be Parkinson's in the individual. What you're seeing here is kind of a more user-friendly version of the telemedicine product. In 30 seconds, somebody can position themselves in front of the phone, a tablet, a laptop, get their biometric results returned to them, everything from the heart rate, the oxygen, and the blood pressure in a very kind of more digestible format. This is our dashboard where we're able to aggregate and risk stratify people based on their suspected conditions. Most likely pregnancy probably isn't a huge area of concern in this community, but you never know. And then this is the multi-pose stroke detection in action. That's a video-based technology that's using the House-Brackman scoring scale for facial paralysis. This is some of the work we're doing for tracking the eyes, looking for degrading of the motion ability to track objects. And this is also for motion tracking, again, to kind of correlate all of this with the other aspects, looking for indications of changes in gait, movement, that could be early indicators of the onset of a condition of concern. So that's it for me. Thank you very much for your time. I appreciate it.
Charlie, thank you. And let's hear it for Dan and Becky and Bob. Phenomenal programs and services and technologies. So I did lie, we're out of time. We didn't leave time for questions. But if there are any, I assume we could take one or two, and then certainly folks are here for you to ask questions. Yes.
And I want to know if are tours available for your facility? Because I'm Carolyn McLaughlin. I'm a county legislator here in Albany County. And I know that our county executive is always looking for innovative ways to improve services here in Albany County. And as chair of the Elder Care Committee for the legislature, I'm interested in, I've gained so much information today, and I'm going to start with you, Dan.
Thank you. Thank you.
Thank you. For Michelle, I was wondering, are there any plans to establish a dementia village in upstate New York?
Yes, so we're actually looking at, our first site would be in Troy, but our hope is that we would be able to expand that across each of our campuses in the capital region. That's a long-term goal. Oh, there's someone in the back. Beth?
Over here, Michelle.
Oh, my.
Hi.
Hi, okay, so while Beth is walking over there.
I just want to say thank you to Dan for
his input. And a question, if money wasn't an option and healthcare plans were not for profit, how fast do you think you could get the setup for elderly people in this country?
Money is always an object. You know, in a dream world fantasy, I think that the models that are there to create holistic programs. You listen to what Becky is doing in the county, and I think it's very easy to, if you could put money and politics aside and not mind whose ox is getting gored, then there's a lot of things we could do if we focused on what's best for older adults, not what's best for insurance companies, not what's best for bureaucracies, not what's best for political officials. What's best for the older adults. I think we would have no problem getting people into great programs, linking them up with what they need.
We have one final question. Hi, my name is Lauren. I'm one of the Eddie Pace social workers, and I was just wondering, because I might be biased, but I do think the Pace model is excellent, and I know the other MLTCs have a bad rap, but I think that we are really doing amazing things to keep our elders in the home, and the program is growing. But I am wondering if you think the budget will end up going up, because we are, at this point, almost one social worker to 100 patients, and it's getting tougher and tougher. So just wondering if it does look like in the next few years the budget will grow.
Yeah, thank you, Lauren. Certainly, we are seeing support from both the federal and state government for the expansion of PACE, and the state has been pretty clear in their position that they're supporting plans that serve the dual eligible for Medicare and Medicaid. And last year actually gave us one-time funding through ARPA, which we used, as you know, to spend most of it on public education about PACE, and our enrollment doubled. That said, there is a tremendous remaining need for growth of PACE across the state and the staff who work in PACE. Move back to you.
So while I have a question for Becky while I have her. No one has asked today about the 1115 waiver, amazingly so, being here in the state of New York. I know that you're familiar with it. Can you just give us a brief update? Sure. I'm sure.
So I will tell you, who's read the 1115 waiver? All right. I have. And so there's two things, Lou, on the 1115 waiver. So we went through an 1115 waiver under DSRIP, if you guys remember that, 7, 8, 9 years ago, that was really tasked with overhauling the healthcare system, making change, reducing ER utilization and inappropriate hospital utilization. Here we are on another 1115 waiver, and we were cautiously optimistic, specifically in the aging population. So one of the nuances about Offices for the Aging is we serve non-Medicaid eligible individuals. What does that mean? Those are, and I always like to tie this back in because we talk about the heroes of healthcare, our heroes that are teachers, our heroes that are state workers, but when they retire, apparently they're no longer heroes because they make too much money to qualify for Medicaid, but they can't afford to privately pay for the service, and we put them on a wait list of 20,000 plus people to get a home delivered meal. Unconscionable. So we looked at the 1115 waiver. Maybe this is an opportunity. You're talking about billions upon billions of dollars that's going to get pumped into the healthcare system, and unfortunately it is laser focused on the Medicaid system. I don't discredit this because it's super important. It's very focused on kids under the age of 6, making sure that there's equities, but there is little to nothing in that waiver that's going to address the older population, specifically the non-Medicaid older population. And I think that's a nuance, and I hate to repeat this. When you look at the state budget, older people pay $72 billion per year in state and local taxes. They're paying for healthcare, they're paying for education. We get 0.8% of the overall state budget to serve millions of older New Yorkers who have worked their entire lives, that need transportation, dialysis, and chemotherapy. They need a home delivered meal, they need health insurance counseling, and they need a home care aide to help them take a shower in the morning to retain their dignity and stay in their own homes. And we get less than $200 million per year in state funding. And the bulk of the funding comes from the localities at the county level who can't afford to continue to offset these costs, that do the right thing on behalf of the older population, and it would solve our long-term Medicaid multi-billion-dollar problem that we have in the state of New York. So long story short, Lou, the waiver is not the answer to our problems.
And I guess that's why nobody talked about it until now. So thank the panel. And Michelle, Dan,